And we definitely appreciate all your East Coasters tuning in tonight. Very grateful for that. And we'll go and get started since we're mindful of everyone's time. My name's Nicole. I'm with the events team, and thank you for joining us for another installment on our SIBO mini-series. Today we have Dr. Mona Morstein with us. Mona is a naturopathic physician for 36 years. She has a practice in Mesa, Arizona, and does in-office and telemedicine visits. Dr. Morstein has specialties in gastroenterology, all hormonal conditions, and chronic disease. For 11 years, she was chair of nutrition, gastroenterology professor, and outpatient clinical supervisor at a naturopathic medical school. She's a frequent lecturer at the SIBO-SOS summits and at other conferences each year. Dr. Morstein is the author of the well-regarded book, Master Your Diabetes, a comprehensive integrative approach for both type 1 and type 2 diabetes. Dr. Morstein has received an award for her gastroenterology contributions to the field of naturopathic medicine and overall award-winning for benefiting the naturopathic profession as a whole. Dr. Morstein has a website, Instagram, YouTube, which I will provide links to in the chat for you all, and she will also put that in her slides. And as a reminder, the replay of this webinar and slides will be sent to you in a follow-up email along with your exclusive discount code. And I'll pass it along to you now, Dr. Morstein.
Thank you very much, Nicole. I appreciate that. And why don't we kind of just dive on in? Hello to everybody here. My talk over the next hour is kind of going to take you through all of SIBO so that I hope when you're done, you'll understand it, you'll feel confident diagnosing it, treating it, and taking it back clinically to your offices tomorrow. And then, of course, I'm certainly open to all kind of questions at the end of my lecture. So I'm going to just dive in. So this is me. My advertising guy who I got told me to tell everybody I have now an Instagram and YouTube channel. So I'm making Mike happy. So there we go. Okay. Now, so we have objectives, but we're just going to dive in. So obviously, IBS is the most common presentation at gastroenterology offices, and it is very common, at least 15% of the population, which is millions of people, and around a huge percentage of that have SIBO, right? Now, we have a little more women than men with this. But you can see up to 65%. Now, studies differ, and some study says this much, that much, but generally there is an idea that up to 2/3 of people with chronic IBS could have SIBO. So it is something you want to acknowledge exists, right? We still have, unfortunately, many physicians and gastroenterologists who don't even believe it's a real syndrome. So we want to trust that it does exist and that it is actually pretty common in our patient population. Now, SIBO, small intestine bacterial overgrowth, is the main term. There is another one called intestinal methanogen overgrowth. Now, this term was invented by Dr. Mark Pimentel, who was the original gastroenterologist from Cedars-Sinai that brought SIBO into the medical paradigm, right? And so with his idea is that the methanogens, even if they're overgrown in the colon, can cause problems really mimicking SIBO and even still need to be treated. And in his idea, which I sometimes agree with and sometimes don't, depending on the patient, any box on a SIBO test throughout the whole 3-hour period that's over 10 indicates methanogen overgrowth and needs to be treated. Now, I don't do that 100% with all patients, but I think if you don't already know, SIBO and EMO are now the terms out there with these conditions. So there are 3 main gases that make up SIBO, right? Hydrogen, which classically is supposed to produce diarrhea in patients. But as we all know, many patients don't read the SIBO manuals. And you get hydrogen patients that are constipated or have normal bowel movements. So we can't always just go by the stool to really understand the gas, because it just doesn't always play out that way. Now, the methane archive, right, not really bacteria, but kind of proto-bacteria, they take 4 hydrogen and make 1 methane. And classically, for sure, this is supposed to be a constipation type SIBO, because methane does medically slow down the migrating motor complex, and that can be up to 60%. However, have I ever seen people with methane who had diarrhea? Yes, I have. How do we explain that? I mean, we don't. It just happens, right? So, however, the more methane, the more they're supposed to get constipated, okay? And then we have the hydrogen sulfide. Now, this tends to be more of a diarrhea type gas, but it has other things associated with it that kind of stand out. As you can read, the peripheral neuropathy, interstitial cystitis, sensitive to noise and sulfur and tingling, numbness. So we kind of want to see some extra gut symptoms. And we'll talk about how to diagnose these gases. Now, the bacteria or archaea, I'm just going to use the word bacteria from now on. We'll all understand that there's some archaea included in that, right? So for hydrogen, tends to be E. coli and Klebsiella. For methane, it's just the Methanobrevibacter smithii. And for hydrogen sulfide, these are the species or the families that we tend to see producing the hydrogen sulfide in the gut, right? Of course, the classic SIBO symptom is the bloating and the distension. And it's going to be hard to think your patient has SIBO if they're not getting bloated and distended. And we've all heard it, right? Patients say by the end of the day, they look 9 months pregnant, right? So that's such a keynote symptom of SIBO because of the extraordinary amount of gases that are produced by the SIBO bacteria, that it's very hard to think about doing a SIBO test if they don't have it. Now, there are other symptoms, the diarrhea, just the IBS, whether IBS-D, IBS-C, or IBS-M, and then obviously you can see other things that go on. Now, abdominal pain and cramping tend to be a lot of times associated with that extreme bloating, the nausea and the GERD, the heartburn that can happen, especially with upper gut gases that are pressing up. Restricted diet, just because people start noticing this food gives them a lot of IBS and bloating. So they start narrowing it down, and we all see patients coming in literally only eating 5 foods out of the plethora of foods on planet Earth, right? If they take any antibiotics for any reason, it seems to temporarily make their gut symptoms better. They might be worse probiotics. So, it's interesting. Probiotics and SIBO, it's like never take probiotics if you have SIBO. I mean, that is not true. We could talk about that later. But the vast majority of people with SIBO can certainly handle the correct probiotics. Worse fiber, right? The SIBO can eat the fiber, or the prebiotics, right? Prebiotics, the oligosaccharides, SIBO bugs can eat that. And we know, I think we know that the number one emotion that's happening with SIBO patients with these chronic problems and the upset gut is anxiety, sometimes bordering even to neurosis, and really not always helped by them being on the internet all the time. But this is, a combination of symptoms we're typically seeing. Now, of course, the main reason in the literature that people get SIBO is because they had a food poisoning episode, post-infection gastroenteritis. And that's up to almost 1/3 of chronic IBS cases happened after they had a food poisoning. Now, food poisoning is pretty common. I always ask patients if they've ever had it, especially presenting with gut symptoms. And obviously, most people who have had food poisoning just get over it and they're fine. And then a certain amount of patient, up to, again, the studies range from 9 to 33%, develop a problem chronically. And it's this autoimmune disease. Now, why do those people get SIBO from the autoimmune disease we'll talk about on the next slide? And why do these people just get food poisoning, same bug, and not develop it? I mean, that is maybe kismet, fate, maybe autoimmunity. We know that there are certain risk factors for just in general developing autoimmunity, like different nutrient deficiencies, food sensitivities, environmental toxins. Maybe already the gut microbiome isn't so healthy. This is why, but we can't yet know that these people will get SIBO and these people will just get food poisoning and recover on their own without a problem. So in one slide, what happens is people get a food poisoning from a gram-negative proteobacteria. This they make, and you can see the 4 main ones there. Campylobacter jejuni is the #1 food poisoning bug. These all make a toxin called cytolethal distending toxin B. And so these bugs get in the person, they're making the toxin, that's causing the diarrhea, vomiting, and then the immune system, it makes antibodies to attack the cytolethal distending toxin, break it down, and clear out the bacteria and get rid of it. And if for whatever reason those antibodies get confused, they also attack a protein on a nerve, right? So the nerve is the interstitial cells of Cajal. The protein is vinculin, which looks a little bit, I guess, like cytolethal distending toxin B. So the immune system gets confused, attacks the vinculin is destroyed. It cannot now, the nerve cannot signal the muscle to move the gut forward. We have the breakdown in the migrating motor complex. We get backwash from the colon. Bam, SIBO, right? So this is how it happens. If you have the cytolethal distending toxin B and no antibodies, okay, you can't get SIBO. If you get antibodies, but you don't attack the vinculin, okay, you don't have SIBO. But if you have antibodies and you attack the vinculin, likely you'll get SIBO, right? So that's, now, what is interesting to know is that this doesn't necessarily happen from Tuesday to Wednesday. A person could have had food poisoning a year or so ago, and it just slowly happened over that time. So we don't need food poisoning just happening to get SIBO. I had one patient who had food poisoning when he was 9 and I saw him when he was like 37, and he'd had problematic gut ever since the food poisoning, which turned out to be SIBO, right? So he had it for 28 years before it was diagnosed, but it may be 1 or 2 years after the food poisoning that, symptoms are developing. So we just need to not rule that out just because it happened a while ago. Now, if it's not food poisoning, what else can interfere with the migrating motor complex? Well, we certainly know adhesions, right? And so breaking down adhesions with visceral manipulation will be a way to prevent recurrence. We certainly know Ehlers-Danlos, the loosey-goosey hypermobility problems. Now, what's interesting with Ehlers-Danlos is many adults don't know they have Ehlers-Danlos. I've had maybe 8 or so patients who we got diagnosed with Ehlers-Danlos in their 30s because they didn't know they had it, but this was the reason the SIBO was recurring when it should not have. And it's really going to occur a lot with the hypermobility syndromes, right? So you have adhesions, you've got lack of digestive enzymes, bile, aside from bile being a fat emulsifier, it's a fantastic antibacterial agent throughout the whole small intestine. So if you're low in bile, bacteria can overgrow more than we would think. The achlorhydria, the pancreatic enzymes, all of these might have a problem. You can see the other things, obviously some more rarer things like a small intestine diverticula, that's not too common. If patients had their ileocecal valve removed because of Crohn's surgery, proton pump inhibitors, birth control pills, I have consistently seen as an etiological factor because estrogen can slow down the migrating motor complex, as well as, of course, opioids. I think we all know. Taking opioids for a week, you can automatically get SIBO. It's like not really good in that regard. Eating disorders can cause SIBO. Traumatic brain injury can cause SIBO. So lots of different things. So it's sometimes easy for us to find out what caused SIBO, and sometimes it's not. And that can sometimes make preventing recurrence more difficult. So when SIBO happens in the gut, it's causing a lot of inflammation. There's a lot of pro-inflammatory cytokines release. The leaky gut can develop. Bile salts get deconjugated, so we can't really absorb fat, and that can cause gut inflammation. Of course, then patients start getting food reactions. The SIBO can interfere with the disaccharidases, which are made in the small gut lining, being made, or it can actually help break them down before they can be used. So this is where, of course, all the desaccharide foods are such a problem for SIBO patients. Of course, then you're not digesting your food. The bacteria are eating it. So there we get all this gas, the bloating, the diarrhea, and then the SIBO just then proliferates and we get more inflammation and blah, 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 this really negative catch-22. There are other conditions related to SIBO, but my experience, like I have had patients with rosacea and SIBO, and we've eradicated SIBO, and they still have rosacea. So, whether it just goes. Now, on the other hand, I have a test case at the end, a patient case where they had another condition. We treated the SIBO, and that condition was entirely cured. So obviously, we have to treat the SIBO. Whether it's going to immediately eradicate the other condition or conditions they have, I don't know, right? Now, it also may be that we have to eradicate SIBO, but we have to take time in then healing the gut and rebuilding the microbiome. And it may be that it may take months until we have a healthy gut, even after the SIBO's eradicated, to have some of these other conditions calm down, because now finally the gut is put back together and healthy. So I would just say, don't tell your patient, wow, you have restless leg syndrome and SIBO, and as soon as we treat SIBO, the RLS is going to go away. It may not, right? So we just have to see. So how do we test when we have a patient presenting like SIBO? Well, there are some conventional labs. Obviously, SIBO may help, may inhibit iron absorption, B12, some nutrients to look at, vitamin D, celiac. So celiac disease should be looked at. Remember, we can only measure celiac if they're eating gluten for at least 3 weeks, like a piece of bread. Otherwise, we have to do the genetic test if they're not eating it, but they're not being 100% dedicated. There are other nutrient analyses from labs that look at the comprehensive red blood cell minerals and vitamins. Obviously, doing a stool elastase, do they have EPI, calprotectin? Do they have an IBD? Do they have a parasite? I know I stand out, but the vast majority of people do not have parasites. My opinion, they don't have parasites, but there's a lot of bacterial overgrowth in the colon that can also lead into diarrhea and gut upset. Helicobacter pylori, you can, and then checking for sure, do they have fructose, sucrose, lactose testing? These come hand in hand. They may come as a result of the SIBO, or they may be instead of the SIBO, and the patient doesn't know and is ingesting the foods that initiate the IBS and the diarrhea. And then if they want, they've usually, by the time they get to me, they've gone to the gastro and they've had at least the most basic testing done. Now, a stool sample. So you cannot diagnose SIBO by a stool sample. I don't care that there's a little overgrowth of Methanobrevibacter. It's not SIBO. It may not even be EMO. You can look at the colon for colon conditions, but you cannot tell a patient they have SIBO by a stool test, right? We know the stool test has zero to do with the small intestine at all, but it can give a lot of information what's going on in the colon. So if someone comes to me and it looks like they need a SIBO test, I will always do a stool test because I need to bring all 25 feet together of the small and large intestine and just see totally what's going on in their intestinal tract. A food sensitivity test, that's always good to do. I always throw in a Candida questionnaire. Now I do the full 2-page questionnaire from the original book on fungal overgrowth by Dr. William Crook, the yeast syndrome, right? And so for me, first of all, we know that SIFO, small intestine fungal overgrowth, Dr. Rao says it could be up to 40% of SIBO patients have fungal. Fungal overgrowth is very common. It can either be in the colon, but if it's negative in the colon and their Candida questionnaire is showing positive, my extrapolation is SIFO because there really isn't any good test for SIFO medically. I mean, you could have a researcher say, well, we're going to do an EGD and go down and aspirate out, some colonic, do a colonic probe and send it for fungus. But, that is the first inches of the duodenum where hydrochloric acid dumps down and the enzyme. I mean, you could have SIFO at foot 12 of the small intestine. I mean, how are we going to get that with a inches probe into the duodenum? So SIFO, I treat a lot of fungal overgrowth. It's very common. And combining the stool with the Candida questionnaire, I think is a great addition. Now, with SIBO testing, they all say, oh, aspiration is the gold standard. But I mean, who's doing aspiration? Okay, so it's the gold standard, but nobody's doing it. It's just beyond, I'm not a gastroenterologist. So you need an endoscopy, it's invasive, it's a research tool. So we're just going to kind of leap through this, okay? So SIBO breath testing, we've got lactulose and glucose. Now, lactulose is the best substrate, right? Glucose is supposed to be pretty good. I have patients who have had glucose testing and it was negative. We did a lactulose and it was positive. Now, lactulose, 10 grams, it's going to go through the whole gut and then into the colon. And so generally we're going to see, the level, and then there should be this rise as it gets into the colon, because of course, these bacteria all live naturally in the colon where they generally shouldn't be causing a problem outside of EMO, potentially, right? Now, So with those who are certain experts or whatever, we're really just going to use lactulose for sure. Now, glucose, of course, the problem with glucose is that it can be absorbed earlier in the gut. It's glucose. And so it can miss out on the later part, the distal, the mid jejunum into the ileum and the terminal ileum and the colon, right? So a lot of SIBO, since it's coming from the colon into the small gut, a lot of times we just see it positive in the terminal ileum aspect of the intestine, and the glucose could be gone by then, right? So definitely you should focus on lactulose with your patients doing SIBO breath tests. Now, the classic machine that is everything that, we've been focused on really is the Quintron machine, where we measure hydrogen and methane in parts per million. The test should be 3 hours long. So if the lab says you can do 2 or 3 hours, always do the 3 hours. We always want to see that colonic aspect, right? You should use a testing company that recalibrates their machine every 5, maybe 10 patients. The one I use recalibrates after every 5 patients, right? So it has to constantly be recalibrated to have it be accurate, right? So it's gotta, got this, it has to read the gas type, the room, it's gotta just measure all of that. So that's the classic machine. There are many labs. If anybody wants to know the lab I use, I'm happy to do it at question and answer. But that's the key one. Now, there is the Trio Smart. So this is Gemelli made up a machine where they say they can measure hydrogen sulfide, which is measured in parts per billion. They have their own system, a non-Quintron own invention, collection, and machine. And so they're saying that, they're comprehensive in these regards. There's a food marble. My opinion, I have not, is that I think it certainly might measure if things are fermenting. Unfortunately, I've done many tests of SIBO, Quintron, and food marble and have not seen equal results at all. And I personally do not use food marble for SIBO testing. Patients want to do it just to see if a food ferments. I don't have any problems with that. This is just my opinion. Everybody may feel differently. I respect everybody's experience, but just to share you what I'm feeling in these regards. One lab, the Commonwealth lab, please never use Commonwealth. This is the lab where you're actually blowing into a straw, into a vial, and then screwing the lid on. I mean, there's essentially no way you can keep out room air in that system. And so that's the one that I definitely feel just is an inaccurate methodology. And by the way, I have no association to any of these companies that I'm talking about. I have no financial interest one way or the other. So obviously, the day before someone does a SIBO breath test, they have to have the prep diet, right? And that prep diet is eating some white fish or chicken, eggs, white bread, white rice, a little tea, just very, very, very basic food. That's the day before. They're fasting for 12 hours. During the test, they don't eat, they don't exercise, they don't sleep. They certainly can drink water. Now, what are the problems that can cause inaccurate test results? Well, it's any if people did these things under the problems, right? We don't want food in the gut, which could feed the bacteria and give an artificial elevation of the test results, right? We just want them to be eating the lactulose. That's it, right? and the other things, right? They didn't fast, they took a laxative, they did some other, if if they vomited before test vial 3, you just have to redo it, just these things. So you want to just make sure your patients know how to do the test correctly, and not screw it up. Now, with the breath test, of course, they need just a certain amount of CO2 to make sure it's from the lungs. We don't want bronchial breaths. And the labs can measure the CO2 to know if it's a good breath test. If they miss one test out of 10, I don't really care. But if they've got 5 or so bad breaths, I mean, my lab will just redo the test for free. So that makes it easier for patients. Now, what if there's not a rise in the colonic, numbers, right, where these bugs live? So if they, this is things to ask the patient. Apparently, they do need a colon. So if they had that removed, then that won't work. Did they, if there's a flat line, that's an extrapolation for hydrogen sulfide. We'll be talking about that. Did they have a heavy dose of laxatives that it went past, the bacteria were flushed out, or they just had a colonoscopy and the bacteria were flushed out, and that a colonic, some things like that. So not having that rise, there's are questions you can ask your patients to see, is it potentially a hydrogen sulfide situation if you didn't do the Trio Smart and you're looking at the hydrogen and methane to extrapolate, or did they somehow do one of these things and we just need to repeat the test? Okay, now interpretation. So a negative breath test, right? Generally hydrogen, here's hydrogen is any number from baseline, the lowest number from baseline to the highest number to 120 minutes. It's not just the baseline number, and that if the baseline number was 9 and then the second reading is 8, but then the third reading is 3, you start at 3 and then you go to 120 minutes. Now, there are some, Dr. Pimentel made an announcement that all the tests should end at 90 minutes. I don't agree with that, and many of us don't agree with that, and the studies don't really yet agree with that. So many of us are still doing the 120 minutes, smallest number to largest number to 120 minutes. Now, if hydrogen is 20 or above, it's a positive test. Okay, so that's how we look at that. With methane, the classic, again, the smallest number from baseline to the largest number by 120 minutes. If it's 12 or above, it's positive, right? Now, many labs following Pimentel's recommendations, not my lab, but many, I think most other labs, if there's any methane above 10 in any box, that alone is a positive, right? And you may want to follow that. Many doctors are following that. I think it's a slippery slope. I mean, if I have a negative methane, and there's one box in the colon that's 12, like, I won't be treating that patient personally for methane SIBO. I won't, right? I think that's me, right? But it's going to be listed positive on many labs because they're all going by Dr. Pimentel's recommendations, right? There is, now, if there is an idea of elevated and sustained, and this is where, say, methane or even hydrogen, the numbers are consistently high. Like, say, every box of the methane is above 10, like every one of them. and the patient really has constipation, but there wasn't a rise of 12 per se. I mean, that does look like a positive methane. And even the hydrogen, if all the hydrogen are 30, 40, but there's not a rise of 20, a patient's having diarrhea, that can be considered a positive hydrogen with elevated and sustained numbers, right? So, I mean, what you might be getting is that there is a lot of gray areas of SIBO interpretation, a lot of gray areas. And there has to be just your own professional interpretation based on the test and the patient, right? Because it's not 100% clear cut, just staring right at you all the time. Now, with hydrogen sulfide, if you're not doing Trio Smart and you're doing a Quintron machine, hydrogen sulfide is generally extrapolated with flatline hydrogen and flatline methane, where we don't even have a rise in the colon. So on those machines, if they're flatline and the patient seems to be fitting the picture, you could say hydrogen sulfide. Of course, with Trio Smart, it's able to measure it in and of itself, right? So these are ways that we can look at SIBO test interpretation. Now, if the baseline is above 10 or so, if the high baseline and the rest of the test was low, probably there might be a little improper diet prep. It may be they sometimes we're thinking they brushing their teeth or chewing gum before they did the test. If so, a lot of times if it's high at the baseline, the rest seems negative, I'm actually personally just going to say a negative test. I'm not going to redo the whole test myself. But if you are very suspicious, you could do that if you wished. Now, there is the other test, the IBS Smart test, which can diagnose if a person did have food poisoning induced SIBO, because it measures for, it's a blood test that patients can now do at home, and it looks at cytolethal distending toxin B antibodies to see if they had food poisoning with that toxin, and it measures vinculin antibodies or anti-vinculin antibodies to see if it initiated the autoimmune disease causing SIBO, right? Now, with autoimmunity, one of my favorite treatments is low-dose naltrexone. Certainly, I do it with many autoimmune conditions, fibromyalgia, the collagen vascular disease, the inflammatory bowel disease, Hashimoto's. It's really great at lowering antibodies. And I would add it in here to try to undo the autoimmunity and in some amount of time, hopefully, and see if they can overcome that situation. Now, the eradication protocol. So these are the 4 ways we have. Let's go into them. Here's the deal with how you do it, the methodology. You do the breath test. You interpret it as positive. You do the antimicrobial protocol. Then you retest SIBO. You don't do another protocol. You don't do this. You retest SIBO. Now, the standard time is waiting 2 weeks. Most of us don't wait 2 weeks. Generally, I wait 1 to 5 days and retest, right? With elemental diet, I'll retest the very next day. But generally around 5 days or so, I retest. It seems to be just fine. Obviously, patients may need more than one treatment, but the reason we retest is 2 main reasons. One, do they still have SIBO? You know what? All 100% of symptoms don't generally go away when we eradicate SIBO. We still might have a damaged gut that has to be rebuilt. They still may have colonic bacteria overgrowth. They may have a fungal overgrowth, right? So it's still good to know, did this protocol eradicate SIBO? And or not. Now the other thing is, was this protocol successful? I get so many patients, they come to me, oh, they gave me, rifaximin and Alamet, and then they gave me rifaximin and Alamet, and rifaximin and Alamet and neem, or they get repetitive protocols and nobody's done retesting. Here's the deal: if that's an effective protocol, there's going to be improvement in the numbers or eradication. If you do a protocol and you retest and the numbers are the exact same, or even worse, the numbers are worse, change your protocol. It's not like rifaximin eradicates every hydrogen SIBO. It doesn't, right? So change your protocol. Too many patients are on the same protocol for months when they haven't been retested, and we don't and the protocol isn't even beneficial to them. So this is a big bugaboo of mine, and I feel very strong that we treat, retest to be the most responsible physicians for our patients. And I get the money, I get that. But generally, if we're doing it right, it shouldn't be more than 1 to 3 treatments, and SIBOs is eradicated and we can move on. At least we know that the protocol was or was not successful. Now, the antibiotics, everybody knows about rifaximin, a Xifaxan brand, rifaximin generic. Obviously, we all know that Xifaxan is really just for IBS-D through insurance companies. If they don't have IBS-D, but they have SIBO, it's very hard to get it, to get it. So we have to order from Canada, where it's ridiculously cheap generically. Now, that's for the hydrogen. If there's methane, then we generally have to add something else in if we're doing antibiotics. Now, what I would say not to do is neomycin and metronidazole, because in my mind, I'm trying to heal a gut that's damaged. Why would I give a patient a broad-based antibiotic that's going to wipe out their gut microbiome, their colonic microbiome? These studies say that one dose of an antibiotic, it can take a year to rebuild a beneficial bacteria to where it was before the antibiotic. So why are we dosing broad-based antibiotics to our SIBO patients, killing their colonic microbiome in this idea to help them heal their gut? I don't get it. It doesn't make sense. I never prescribe those drugs. But Alinea, which is nitazoxanide, this is an antiparasitic drug. It's an antiviral drug. It is not a broad-based antibiotic in any way, shape, or form. It's also more expensive than rifaximin. And when we have a parasite and we're going to prescribe Alinea, generally the prescription is, right, 1 twice a day for 3 days. Well, we're going to do it for 2 weeks with a SIBO protocol. So you can't really get that through American insurances. It's just so not prescribed that way. So we generally have to get it also from, where it's, I don't know, $2,000, $3,000 in the States. It's $60 for 4 weeks of it in Canada, right? So I order a lot of stuff from Canada. But that's the 2 combination that I want that works very well. And then I can be relieved I'm not killing their microbiome in the treatment of SIBO. Now, rifaximin, of course, we all know rifaximin. We love that. It only works in the small gut. Studies say if it affects the colon, it actually increases bifidobacteria. It is not absorbed by the human gut. It doesn't cause genetically passed down resistance, right? So we love it. It's super safe. If someone comes to me with a sinus infection, I don't prescribe antibiotics. I have naturopathic medicine. I don't need to. I don't like antibiotics. But I love Xifaxan, right? Now, a couple of things about Xifaxan. There was a study showing when it was combined with guar gum, the eradication rate went from 62 to 87%. That's a lot more eradication. Please mix a tablespoon of partially hydrolyzed guar gum into it. Also, bile has been shown to enhance rifaximin's effects because it's active only in the small gut because it needs bile to solubilize. The colon is watery. It doesn't act in there. So we give rifaximin with breakfast, but then we give it 8 hours later, mid-afternoon and evening when we're not eating. And so taking it with a little bile, and by a little bile, I mean no more than 200 milligrams. Don't give 500, don't give 1,000. That's going to whack their gut out. Little dose, 1 to 200, that should be enough, right? And here's the guar gum and bile acid studies if you're interested in those, okay? But I always combine those two together to enhance effectiveness. If you've heard of guar gum, I mean, not to blow my own ego, but I was the one who brought this into the SIBO world. And I hope more people are combining it for more effectiveness. Now, we do all of those for 2 weeks generally, right? The natural antibiotics we generally do for 30 days. You want to combine three or four of them together. Do it. They can be equally effective. There's many different combinations. Garlic is mainly is for methane, but neem is methane and hydrogen. Oregano, methane and hydrogen. Berberine, methane is more hydrogen. And then these other combination products and other things that are out there can be used as well. Generally include a biofilm buster because these bacteria can cause biofilms. Generally, there are products, there are supplements that we use as biofilms from different companies. They generally, these bismuth products are kind of the best ones, right? Probiotics, again, probiotics have a bad name with SIBO. There's only 2 probiotics I use with my SIBO patients, but you can see that it helped with the SIBO eradication. We want to make sure that there's no prebiotic, and whether you're using bacteria or spores, that's up to you, right? They innately, both of those without prebiotics are, can be helpful. Of course, the last is the elemental diet. Does it always work? No. I just had a patient choose to do an elemental diet, and the methane went from 16 to 9, which is great, but her hydrogen went really, really, really high, which is amazingly frustrating. So elemental diets can raise methane. Sometimes it's not the #1 most best way to go. So most times patients don't want to do it because it is difficult. But you just want to let patients know it could be effective. I've seen it be immaculately effective, or it may not be effective. Certainly you want it without dextrose. And there's a new one out. It has dextrose. Dextrose, the very first elemental diet that came out with dextrose. But we all started using it, and everybody got, my patients, like I got thrush in a patient, like horrified me. I'd never given my patient anything to get thrush, but it causes fungal overgrowth. And many patients with SIBO have fungus. So then you have to then give an antifungal with it. Or guess what? You can give an elemental diet without dextrose in it. The company immediately within months had made a dextrose-free elemental diet. That's the one I've been using, and it never causes fungal overgrowth. So I would really just avoid dextrose ones, right? And then, you have to make sure they sip on it slowly and over 30 minutes and get their caloric intake. I had one patient who didn't want to do the elemental diet drinking, but did a carnivore diet, and that actually eradicated her SIBO. So I guess we're just trying to starve. That's what we're doing. We're starving the SIBO bugs to death, and they don't really eat protein. They don't eat amino acids. So I guess carnivore diet is an option. Now, after SIBO's eradicated, we need to give a prokinetic to prevent recurrence, right? The prokinetic is making that migrating motor, making the gut move so there isn't, backwash, or we're just getting better cleansing waves to keep it clean every day, right? Now, they have to be on this for a year or two. It's not a quick thing. Oh, just take it for a month and you should be good to go. No, they have to be on it for a while, and even potentially longer if it is an autoimmune, antivinculin situation, or all forever if they have Ehlers-Danlos, or they don't have an ileocecal valve or something that is chronic. They're on opioids or something. Oh, although opioids, are going to be stronger than some of the prokinetics, that's for sure. Now, there are many supplements that are prokinetics, right? There's also medications, right? The first line, and then the Motegrity that people like because it helps reduce methane, and low dose erythromycin. The 50 milligrams a day does not act as an antibiotic. So these are, you want it now. There are weaker supplements, stronger supplements. There's then medication, then there's compounding like the erythromycin, and then there's the drugs, right? So where's your patient? If they have chronic idiopathic constipation and SIBO, you might just need to really leap to one of the drugs. But if they generally have a bowel movement every day, it's not that bad. You could do a weaker supplement. Notice I don't have low dose naltrexone. That is that's just not really a prokinetic. Don't please use it as a prokinetic. Now, here's a great thing, really great clinical pearl. Your patient has SIBO. Their SIBO is cured. They're going to now go to, travel in Vietnam or India or Thailand or South America. And now I'm not trying to be geographist or something, but these, if they're going to go to a country where there's a higher risk of food poisoning for an American or Canadian, then they're likely going to get food poisoning because SIBO patients have a higher risk of food poisoning. So I give them rifaximin 200 milligrams, or if they have leftover 550s, you can just cut it in half and do the 275. They take one a day throughout their whole trip. They won't get food poisoning. I have got like 5, test cases where patients went with their family to Vietnam, or they went to Colombia, and everybody gets food poisoning, but the SIBO patient on their daily rifaximin. Now, you can also do natural sometimes you can give them a strong garlic instead, or berberine, things like that. But honestly, rifaximin, which is dosed for food poisoning, for gastroenteritis, giving them a 200 as they travel, it's magnificent. Now, so for me, the way I do it is I treat SIBO, eradicate it, and then I want to heal the gut up. I don't try to heal the gut up before the SIBO's gone, because I think SIBO is what's damaging the gut. So I want to get rid of what's damaging the gut. Then I feel we can heal it up, right? And so then put them on temporarily a therapeutic diet, maybe just 5 or 6 weeks. That's it. And then give them things to heal the gut, help digestion, and so forth, right? Obviously, I might need to be addressing their fungal overgrowth or bacteria in their colon. Vagus nerve toning. So for the heart rate variability, to measure the vagus tone, I do this combination of, there's a free app called Elite HRV, and then I combine that with as if on cue, the Polar H10 heart monitor, right? So they'll pair 1, 2, 3, and then they do their breathing, and they'll measure their heart rate variability, which is an indication of vagus tone. And then if it's low, we know we need to engage in really intense vagus toning exercises in their healing process. The SIBO diet, generally is focusing mostly on disaccharidases. I generally don't, like I say, I don't like to do restricted diets. I'm the big doc for saying add this in, add that in, add as much food in as they can. Let their body tell them what they can and can't eat, not what some lecturer says, right? There's a lot of pros to a restricted diet. Just symptoms go away, the gut can heal, we get rid of the inflammation, the leaky gut. But the cons is, it affects them mental, emotionally, socially. It's a lot of time and energy, traveling problems. So I don't like to be on it for too long. I'm a fan of a modified special carbohydrate diet. I start strict and then week by week open it up. There are a lot of really great cookbooks. The special carbohydrate diet by Raman Prasad. I can put that in chat. Great book, right? I mean, if they've got some cookbooks, it really makes it so easy in this regard. But that's the one that I like to use with patients. And then, of course, there's the low FODMAPs, which is a terrible diet, so unhealthy for the gut. And people should just be on, again, 5 or 6 weeks. We should not have people living on a low FODMAPs back for a year or 2 or 4 or so forth. They're going to have a much weaker, unhealthy gut as a result, right? But at least it can give us an idea if this is a problem in their gut. Something is affecting their capacity to digest these foods. Other supplements, for sure, healing the gut, the intestinal permeability, the building it back up, nerve regeneration, and intestinal support. SIBO does cause intestinal permeability. In one study, they found it in 55% of patients. And so we do want, I'm sure you guys, glutamine. What's nice about N-acetylglucose aminoglycan, everybody knows glutamine, 5 grams a day, 10 grams a day, whatever. N-acetylglucose, glucosamine or glucosaminoglycan, NAG. NAG is like slippery elm in healing the gut and the mucus, but slippery elm has carbs in it that may affect a SIBO patient. So NAG does not. So it's very safe at all times for SIBO patients and is just so healing. There's one study with using NAG with IBD patients, pediatric IBDs, and they took 4,200 milligrams a day, and there was an erratic, these kids, many of them went into remission, which of course most of us never see in clinical practice, things that simple, but nonetheless, it's also really great for interstitial cystitis patients because it helps build up the mucus lining and reduce inflammation in the bladder as well. With nerve support, I talked about low-dose naltrexone if they have the autoimmune disease. Lion's mane to help, is a nerve growth factor. Acetyl L-carnitine is great for healing nerves as well. I put everybody on a very good multiple vitamin mineral. I want all the nutrients easily accessible by their body. I put everybody on fish oils for healing the microbiota, increasing butyrate. It's anti-inflammatory. It's good for the brain. It's an antidepressant. It's anti-anxiety. Like, it's awesome. So I'm always doing these things. Now, your patient has recurrent SIBO. Why is this happening? One, they didn't get a prokinetic. Okay, that's the case like with gastroenterology. Unfortunately, they give the rifaximin and then say, goodbye, see you. So they never get a prokinetic. So they didn't get a prokinetic. They got a prokinetic, but just thought they had to take it for a couple of months, and that's all they did. They got the prokinetic, but it wasn't strong enough for what their system needs. So it recurred. Or they're on a good prokinetic, but the underlying issue is still going on. They didn't know they had Ehlers-Danlos. They still have adhesions in their gut from previous surgeries. They're still on a PPI, or the EDO is still active, right? And so for these patients, like with my Ehlers-Danlos patients, we eradicate SIBO, and then I keep them on rifaximin 200 milligrams like every day, every single day for the rest of their lives. And instead, I had one patient, she was getting SIBO, she got it like 5 times in 1 year. We eradicated it. She was 35. We found out she had Ehlers-Danlos, and I kept her on rifaximin, and she didn't get SIBO for nearly 5 years. And then we had to treat it again. And now it's been another 8 months she's been free. So, this is pretty good. She was pretty happy with that. So here's my test patient. This is a patient, she had chronic diarrhea. She was actually diagnosed with microscopic colitis, which is interesting because that's solely in the colon, right? It's diagnosed by colonoscopy and a biopsy of the colon lining. But we did a SIBO test, food sensitivity, and a stool test. Now, on your handout, I had made a typo where I said she was just positive to hydrogen, but she was actually positive to hydrogen and methane, which is why you'll see I added in the methane. That was just a typo, sorry. And there is a good study that SIBO and microscopic colitis, they tested 67 patients, and in the ones that had lymphocytic microscopic colitis, 19 of 54, and in the collagenous, 5 of 14. So it is present in these patients in the literature. So here was her SIBO test, and you can see that her methane is ridiculous, and her hydrogen, right, we go from 1 to 27, right? So that's 26. We don't go, it's the lowest number to the highest number. And here it's the lowest number to the highest, which actually happened in numbers 1 and 2. So I gave her rifaximin, and now you're going to say, you are such a hypocrite. You gave her metronidazole. Well, I did 7 years ago, before I had that old light bulb over the head. I haven't given metronidazole for 4 or 5 years now, right? So, but I did then, and I also gave the guar gum and the with each dose, and the follow-up, crazy. Her follow-up, I mean, I would not have expected she would have gone from this bad a SIBO to this good a SIBO. That's wackadoo, but she did. And I can't explain it. I wish it would happen with other patients, but it doesn't necessarily at all, right? And of course, we love seeing again these elevations in the colon. And her microscopic colitis, diarrhea, completely stopped. Totally. Stools fully formed and normal. And and I've kept in contact with her. This is 7 years later. She's never had it recur. She's completely fine. She took the prokinetic for a year and then stopped. It's been 7 years and she's never had it back. Daily form bowel movement. So it's these kind of test cases that, here's the deal. I've been in practice 36 years. For 13 years, I lived in Montana. And in Montana, when you drive early in the morning or like around twilight on a road in the forest, you're going to see a deer, right? Or several deer. And it's always exciting. Oh, look, a deer. Oh, or rarely an elk, but it never got old. It was always exciting to me. And thank God, medicine, it's still exciting to me after 36 years, to cure a patient of microscopic colitis that they've had for years. And I don't know, it never gets old. And even though SIBO can be so frustrating sometimes and so pull your hair out at the roots at times, it's these beautiful interactions with patients that just keep us always moving forward. All right, I'm done. Thank you very much. Open for questions. Oh, here's a little summary page. We don't really need that. I'm going to stop sharing, and there we are. So, okay. So we have, should I just dive into all of these questions,
Yeah.
Nicole?
Yes, there's some in the Q&A chat if you want to take those, and there's
Yep.
also
Well, I've got, oh, okay. I'm in the webinar chat. Should I do that or the Q&A?
let's start with the Q&A one.
Okay, gotcha. So the Q&A. Okay, so food sensitivity for Kevin, doctor. I'm just gonna call everybody first name. Please don't take it. Please don't be insulting. Absolutely Alletes, 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 which is actually they must have gotten it in early, but they're at foodallergy.com. I've been using them for 20 years. I've been to their clinic. I've seen how they put it together, their commitment. This is what they've been doing for 60 years. That's the only food sensitivity test. It's affordable. It's accurate. I love it. I have not seen the test she's talking about, so not sure what she means by colon box. I don't know what that question means, Carol. Please just ask it again, but give me a little more info. I'm sorry. If a patient is drinking hydrogen water, can it cause hydrogen gas to increase or be problematic if they had SIBO? I mean, that's a really good question. I don't believe it would have anything to do with the SIBO test, but just for the heck of it, I would say at least don't drink it the day before and the day of the test. So that's all I can say in that regard. Oh, there's Carol again. If you're testing in 0 to 5 days in treatment, does this mean you can prove or eliminate SIBO? Yeah, look at it. I think it's funny with SIBO. I mean, I think of if I say I'm a conventional doc and someone comes in with a sinus infection and I give an antibiotic for 10 days. At the end of the 10 days, wouldn't I expect their sinus infection to be over? Or would I say, let's wait 2 weeks and see if your sinus infection is over? Or think of that with a bladder infection. Oh, I gave you a bladder infection. Let's wait 10 days and then we'll recheck it. People, it should be over. It should be gone. We gave them medicine. It should be controlled. So if SIBO is eradicated in the test, I am going to say that is a valid test for eradication. Anonymous, no prebiotics. So prebiotics feed SIBO bugs. And that's so if you give a probiotic that contains a prebiotic, they can get a lot more gas and bloating and symptoms from it because the inulin, the chicory, any of the oligosaccharides, the fructose oligosaccharide, the galacto oligosaccharide, the xylo all of those feed active SIBO. That's why no prebiotics. I was just treated with amoxicillin clavicular for diverticulitis. How can I rebuild my microbiome? Okay, so generally that would be a combination of giving probiotics, but also a lot of fiber and prebiotics, right? This is so where, remember, probiotics don't really colonize in the human gut. They do, we call them, I had one lecturer I went to call them happy tourists. So they go through the gut, they go through the gut doing everything you want, helping with detoxification, helping heal the gut lining, anti-inflammatory, helping digest food. They're doing all these things and then they pass on through. Where prebiotics are what are feeding and enhancing and causing proliferation of the gut microbiome. So so I would mix those two together for patients at least 6 months, frankly. The studies say up to a year. So we'd want to just support it regularly. Now, of course, taking probiotics with the antibiotics, taking butyrate with antibiotics, taking antifungals with antibiotics, like these we can try to do just to be protecting the gut as much as possible while we have to take antibiotics. So pharmacy in Canada, I generally use 2. One is fairly well known, Mark's Marine Pharmacy at Can Ship Meds. And the other one I like a lot is your Canadian drugstore. which is your ycdscc.com. So those are the two that I use with my patients. I don't know about the slides. I think they're sending them to you right when we hang up.
Yes,
If I
that's
can't, I mean, I can prescribe, any of us can prescribe rifaximin. It's just that the insurance companies won't cover it unless, now, if you're a gastroenterologist, since they're specialists, insurances usually put it through for them. I'm not a gastroenterologist. And if I can't do a pre-auth that says IBSD, if I have IBSD, they could very well cover it. If they don't have IBSD, I can't write IBSD because that's insurance fraud. And I can't, if they have IBSC, I have to write IBSC. So they weren't going to cover it. Now it does take about 3 weeks to get it from Canada. So I guess you have to treat them after they come back from vacation. So I don't know. Who wants to do the whole protocol on vacation anyway? Biocidin. So I do use biocidin sometimes kind of as a biofilm buster, or I'll add it in with other supplements. So yes, I have used biocidin. You can't use it by itself, but to mix it in with other supplements, yes, I have used it in that regard. Have I seen SIBO or parasites cause tongue or lip aphis ulcers and facial rash? Well, as I said, I do stool testing on literally, every single day I'm doing stool testing. Patients, the vast majority of patients don't have parasites. I just, 36 years, I have just not seen that. Now, when I was practicing in Montana, yeah, those farmer ranchers had parasites because they had well water, and on top of it was a bunch of cows and chickens and pigs. Okay. But Western people in a city, I don't see it. I see loads of bacterial dysbiosis, though. But anyway, SIBO is associated with rosacea, acne rosacea, as I've said. I don't know what other facial rash you might be referring to. Artemisian considered to be an antibiotic. Well, artemisinin is generally used, I didn't pronounce that correctly, is generally used as an anti-parasitic and an malaria drug, right? Or preventive malaria drug, but it's generally mostly for parasitic, aside from just an antibiotic. You could always use it with probiotics, sure. It wouldn't be a problem. I don't understand what's my protocol for IBS-C. I have to figure out why they have IBS-C, and then I will treat the reason why they have it, right? I don't have just some innate form, that everybody gets. We have to figure out why that's going on. With kids, that can just be because they're eating garbage all the time, and you just have to get the parents to feed them some fruits and vegetables, and whole grains. That can, that it can be sometimes that simple, but it may be other things going on. Fungus is a constipating microorganism. SIBO can be a constipating microorganism. Their medications might be constipating. They might not get enough water. They might not have, there could be so many things going on. All right, that's the end of the Q&A. Should I switch to the webinar chat, Nicole?
Yeah, there's definitely a few more questions in there as well.
Okie dokie. 203 of my patients came back with entometa histolytica. Yeah, I saw that was a common one in my Montana patients. It depends on what lab you're using. I don't like, there's one lab a lot of people use that I don't trust at all. I wouldn't, I don't use Parasitology Center. That's just me. I have not had good experiences with that. Entomoeba histolytica, that was with my Montana patients. I have, I'll have maybe one patient a year have a parasite, right? So I don't know, it depends on your labs. There are some labs that just are bad and their probes are bad and I don't know. So the book to get the Candida questionnaire should be The Yeast Syndrome by Dr. William Crook, literally spelled like crook, Crook. And I like the 2-page full one. Somebody made like a seven question one. Why would I do that? I want the 2 full-page one. It takes patients 5 minutes. I want the full one. I don't want the abbreviated one. The protocol for LDN. So the way I do LDN is I first prescribe 42 1.5 milligram pills, and I have them take 1 at bedtime for a week, then 2 at bedtime for a week, then 3 at bedtime for a week. I let them know that pretty much the side effects might be some vivid dreaming, which tends to go away within several days, and then sometimes just a little tiredness in the morning, a little sleep difficulties. And that may happen. I mean, the side effects may happen to patients so that they can't take low-dose naltrexone, maybe 5%, 8%, not many, especially with the titration. I don't think it's necessary to do 0.5, then 1, then 1.5, then 2. I mean, it would take forever to get through it. So I do 1.5, 3, 4.5. No refills. Patient then lets me know which dose they handled the best, which is usually 4.5. But maybe it's 3 or whatever. And then I call that in for the year, right? So that's my kind of 2-step way of doing LDN. We should retest, Naria, retest after the end of every SIBO eradication protocol. Retest, right? Yeah. So I use Nestle's Nutrisource fiber, which is partially hydrogenated guar gum. Sun fiber is partially hydrogenated guar gum. So you can easily use that as well, right? Pectosol, I think, is modified citrus pectin, which is to give to patients who have cancer who are going to get a biopsy or a surgery to prevent, metastases by disallowing them, the individual cancer cells, to get through the basal cell lining. So I don't think Pectosol, I think that's a modified citrus pectin. Ehlers-Danlos, exactly. So the Ehlers-Danlos, you can, if you Google like Ehlers-Danlos Biten test, the Ehlers-Danlos Society has a free 3-minute test that patients can do at home to see if it looks like they have Ehlers-Danlos. And then if they've got a high score on that test, then you got to try to find a doc who's not booked out for 9 months to verify it, or you can just assume, wow, it looks like that could be the reason you're having all these frequent recurrences. So how do I recommend patients purchase antimicrobials? I mean, I just take them to the website. I say, it's all on my treatment sheet that I give patients, but you have to write out a script. So you have to write rifaximin 550, number 90, the SIG, refills. You will, so you need a prescription pad. I know most of us don't use these. We're all doing our EMRs, but I buy prescription pads specifically for this. I just email them the prescription pad. They have to upload the prescription pad at their checkout to show it's from a doctor. And then they just pay for it and it's shipped to them. It takes about 3 weeks. So works out really easy for patients in that regard. Yeah, Elaine Gottschall wrote the Special Carbohydrate, Breaking the Vicious Cycle. That's the original book that came out on that. When will this webinar end? Kind of hurts my feelings, but soon. And let's see. So Prokinetic. If you look, this is completely bad, but I did make a line of supplements through Priority 1, including SIBO-MMC. My experience, but I am so biased I have monetary association with this product, clearly. But I use that for the worst case scenarios of like constipation, but not so bad they need a drug. Other products like motility, motility activator or motility complex, these supplements with just the ginger and the artichoke, if they're like got a normal bowel or they even have some diarrhea, where those are those are the simple products that I'll use for a prokinetic. Oh, since I don't like well, I use parasite testing is just through the stool sampling that I'm doing, right? So that's, I'm using what I think is a good stool sample with really high class probes. And so I'm just relying to pick it up on the stool sampling if it's actually there. Have I had GI side effects from lion manes? I have not, ever. Zero. Not at all. There's a new research showing a genetic component for hyper. Yeah, oh, that would be fantastic. Oh, thank you for that info. The stool company, for many, many years, I used doctor's data. And now I've switched lately to US Biotech's, their GI basic or GI advanced test. One thing I like about, I haven't used Flore, but what I like about Flore, and I'm starting to feed my patients to, is Flore will make individualized probiotics based on stool tests for patients to make bugs specifically for what their gut needs. Again, I have no money associated with Flore, with doctor's data, with US Biotech, but I find that very intriguing. So if I do a US Biotech and I see that they have low beneficial bacteria, I can send that test over to Flore and they can make an individualized probiotic for my patient. So that sounds interesting, and I'm starting to do that with patients. Where are your, so my virtual patients? So I use Aerodiagnostics for SIBO breath tests. And Gary Stapleton, sends me 30, 50 tests, and they have lactulose, and then I give them out to patients and I mail them to patients virtually, and they come with the lactulose because they're coming from me. So it's really easy. So I just get them and send them out and use them with my patients. It's super simple virtually, right? Yes, Flore for individual probiotics. That's spelled just that way. I hope this has been helpful for all of you. I love SIBO. Sometimes I hate SIBO. But I love sharing it. We've got to have really good SIBO docs out there, knowing how to really treat this complicated condition. So what with these protocols, what do you have? Oh, okay, so high histamine and mast cell. That's, maybe, I don't know, microbiome can have me come back and I can talk about that, but that's a big situation in and of itself. Food marble for testing, I do not use food marble for SIBO testing. My experience was that it wasn't accurate, my personal experience. So, it seems like some of you, it seems like this was a good lecture. Yay, woohoo! So thank you. I've been delighted to be here and share what I know with all of you.